Welcome everyone to another episode of Mindlessness, the Power of Articulation's Clinician series. I'm Dr. Toye Oyelese, and today we're rolling up our sleeves and getting practical. If you've listened to the first two episodes, you know we've spent some quality time with the why, unpacking the framework and the odd magic of mindless repetition. But today I want to give you a clear path for implementation. It's that nuts and bolts episode where if you've got a notepad, you'll probably want to have it handy. So, let's dive right into your role as a clinician here. See, with this approach, verbal articulation therapy, your job is not to sit back and your way through, hoping that the patient hits some insight that changes everything. Instead, you're what I like to call an active facilitator. Not the big boss barking out orders, but not just a neutral reflector either. Your hands are on the steering wheel, but the patient's got their foot on the pedals. It's about guiding them through a very particular structure, without putting your words in their mouth. People sometimes ask, can you just give the patient the articulation and get it over with? And the answer is, that kind of defeats the purpose. The statement has to resonate with them. It has to feel and sound like their own words, or it doesn't stick. Years ago, in my first few months working in Kelowna, I remember getting tempted to just hand out the words. I'd get impatient when someone was stuck, wanted so badly to jump in and say, "How about this statement?" But the times I resisted, waited for them to wrangle with language, that's when things actually moved. I'd see them trying out options, getting frustrated, laughing at a silly word, and finally landing on something that actually felt right to them. You don't have to over-explain the theory. Keep it simple, like, look, we focus on what you say out loud because that's something you can control, even when your thoughts and feelings seem totally uncooperative. By getting your spoken words and actions going in the same direction, your thoughts often catch up. That's it. Patients don't need a lecture. They need a sense of what, practically, they're being asked to do. Less is more here. Alright, let's get to the protocol itself. It's a 6-step process. Structured, but honestly, pretty accessible once you get the hang of it. And, just a heads up, if you've got a long, complicated clinical day, knowing the flow helps things not go off the rails, trust me. So step 1, framework education. That's what we just talked about. 2, maybe 3 minutes explaining the SW plus A plus T equals D. But in plain language, you say, you've got what you say, what you do, and what you think. Thoughts being the hardest to wrangle. But what you say, you can always choose that. Let them know that it's about setting a positive direction using spoken words, not about believing or analyzing, just saying. Step 2. Do a current state assessment. Ask your patient for 2 or 3 action words that describe their current direction in the area they want to change. I might say, if you had to use just a couple of verbs, what are you mostly doing right now? You're listening for honest words, worrying, avoiding, doubting. Now, if they give you adjectives instead of verbs, anxious rather than worrying, that's fine. Don't correct them. The word will in the articulation does the work. Anxious becomes, I will be calm, and that's still an action statement. The will be construction turns any adjective into a direction. Then, step 3, desired state definition. Simple, but don't rush it. You turn to, okay, let's flip those. If you were pointed in a positive direction instead, what verbs would capture that? So, worrying might become trusting. Avoiding might turn into engaging. And the trick is to avoid those not constructions. It's not helpful to say not worrying. Better to name what you'd be doing instead. Step 4. Articulation construction. This is where you stitch those verbs or adjectives into an I will statement. Future tense, always. Now, confession time. I still, after all these years, get tongue-tied on articulation. Usually, I say it 3 times, slow down, and stumble. For some reason, my brain wants to say articulational. Anyway, it's a good chance to show patients we're all human, and it lightens the mood. Focus on clear, direct statements. I will be confident and decisive, or I will trust, I will engage. Do a resonance check by having them say it out loud. If it feels awkward, adjust. Every word should land comfortably. If confident is a stretch, but secure fits, go with secure. It's got to be theirs. Step 5. Repetition prescription. Don't be vague here. Give specific numbers. Baseline, 10 reps, 10 times a day. I often tell folks, do a set in the shower, maybe one in the car, another after lunch. Just spread them out throughout the day. For tougher days, crank up the ratio, 100, 200, even 300 repetitions if they're in crisis. And crucially, only one articulation, one focus. Don't let them split across several problems. The value is in repetition and concentration. And of course, step 6, confidence and conviction monitoring. At every follow-up ask, on a scale of 0 to 100, how confident are you that you'll actually do these repetitions? And how convicted are you that this direction fits? If confidence or conviction is under 80%, that's a signal to troubleshoot. Practical barriers? Words don't feel right? Figure it out together. Sometimes the statement just needs a tweak, and sometimes the problem is logistical. Either way, you address it right then, right there. Remember, as we discussed in the last episode, the power isn't in convincing yourself it'll work. It's in the plain, repeated doing. Don't try to believe it. Don't analyze. Just say it like you're brushing your teeth. That's where the magic, if you can call it that, happens. So let's talk about what can go off track. Because honestly, when clinicians start using this model, there are some classic mistakes. First, the urge to over-explain. Maybe you're eager. Maybe you want to make sure the patient buys in. But too much theory does not help. Nobody needs a deep dive into neural pathways or cognitive dissonance at this point. Like I said earlier, keep it practical. It's all about the doing. Mistake number 2 is, you guessed it, supplying the articulation for the patient. It's easy to think, well, this'll save time. Problem is, the articulation won't resonate. It'll sound like your voice, not theirs. And I see this every month in supervision groups. Clinicians want to be helpful and end up doing the heavy lifting for the patient. Third, allowing them to split articulation across different issues. I've made this mistake more than once. Someone starts with, I will be calm in meetings. I will stand up to my mum. I will walk more. Nope. Hold the line. One statement, centered on the core direction, even if it means some discomfort at first. Fourth, vague instructions. If you say, repeat this throughout the day, you'll get 10 repetitions, or none. If you give concrete numbers, patients actually know what to do, and, shocking, I know, they'll do it. Last, forgetting the mindlessness piece. We all want proof something's working, but constantly checking, is it helping yet, just gums up the process. Remind them, don't analyze, just do. Now, quick word about boundaries. There are times when this protocol isn't enough. Think of the glasses caveat, like teaching someone to drive before they get their vision sorted. If a patient is so distressed they can't even participate in this conversation, can't generate a single positive direction word, or their confidence is flat 0, This is when you pause and look at neurochemistry. Sometimes pharmacological support needs to come first, or alongside. It's not a failure, it's good clinical judgment. For example, I had a patient, years back, who just couldn't come up with even one positive verb about their future. Total blockade. That was my cue to step back, check if depression or severe anxiety needed more direct intervention. And that's fine. This method often works in tandem with medication, building traction as symptoms start to ease. In the end, remember, it's about being directive on process, collaborative on content, and flexible enough to recognize when another layer of support needs to come first. Avoid the common missteps, tailor the protocol thoughtfully, and your patient will have a good shot at real change. Next time, we'll dig into the boundaries and applications. So, which presentations is this protocol best for, and when might you need to choose something else entirely? I hope you'll join me for that episode. Until then, thanks for spending the time with me, and give those articulations a try.